Hello class, I have already posted the PDF file of part 2, lecture on skin infection. So this one is the audio file. And if you will remember, we started off with the fungal infections of the skin, and we were able to discuss the superficial mycosis and the cutaneous mycosis. So if you still remember, we said that fungal infections are classified based on the major sites of involvement in the body. So we will now continue with the next group of fungi that are associated with um, subcutaneous mycosis. So we're now going deeper, so underneath the skin. All right, we start with the first one, that's sporotrichosis. And this is an infection that is oftentimes associated with subcutaneous tissues and also the lymphatics. So this is usually acquired through trauma. Okay, so there's traumatic inoculation, meaning there is some sort of trauma either in the upper or lower extremities, and this trauma will be the site of entry of the fungus into the body. So usually this appears in the or occurs in the hand, in the arm or leg. And sporotrichosis is also referred to as the rose gardener's disease, because oftentimes the affected individuals are farmers, miners, um, gardeners, and florists. So it is an occupational hazard. And this is how the lesion will look like. So obviously the lesion starts here in the fingers and it is left untreated, and therefore the lesions have extended into the hand and even into the arm. Okay, so this, as I had mentioned, occur not just in the upper extremity, but also it can occur in the lower extremities. Now, the etiologic agent of sporotrichosis, we call it as Sporothrix schenckii. So we had encountered these different fungi when we discussed the classification. I gave you the names of the etiologic agent, and as I had mentioned, you get familiar with the names because it's not easy to memorize all of them, but you have to do it again and again. And as I had mentioned, you have to practice also writing the names so that you'll be able to get the correct spelling in case it will be asked in the VSA, type of exam or tests. So if you still remember the Sporothrix schenckii, previously we also um, describe them as a dimorphic fungi. So if you still remember dimorphism, how did we define dimorphism? These are fungi that grow into two different forms if they're exposed to two different thermal conditions. So they grow as a mold form or mycelial form if they are exposed at room temperature, and they grow as yeast forms if they are exposed at 37 degrees Celsius, which is body temperature. Now, the clinical specimens that are oftentimes used for diagnosis are aspirated pus from the lesions, from the nodules or swabs, okay, or scrapings, or even a biopsy tissue, from the affected area. All right, the macroscopic description, meaning this is how the colonies will grow on SDA. What is SDA again? It is saborrhoed dextrose acar. So they're rapidly growing about 3 to 5 days. So they're described as white, pasty, moist colony. So these are yeast forms, right? that later becomes brown, black, or wrinkled or leathery if you incubate them for a longer period of time. But generally, they appear as yeast colonies. So this is how the colonies of Sporothrix shenki will look like, as I have mentioned, using Saborode dextrose agar. All right. Now, microscopically, now the mycelial forms, or the ones that are grown at room temperature, they're actually described as pyriform conidia arranged singly or in a floweret. So if you look closely, these are arranged in flowerets. Okay, so that's the mycelial form. And if you grow them at 37 degrees Celsius, which is body temperature, right? And therefore, this is the form that you'll be able to see when you do scrapings, when you do biopsy of the tissues that's affected. And it is being described as small elliptoid budding yeasts, right? And they have a characteristic cigar-shaped appearance of the yeast cell. So if you look at these areas closely, you'll be able to see yeast cells, small yeast cells that have a cigar-shaped appearance. Okay, so this is the dimorphic forms of Sporothrix shenki. Okay, so to continue with the subcutaneous mycosis, we have mycetoma. So this is another type of mycosis affecting the subcutaneous tissue. This is also referred to as Madura foot or the maduromycosis. So these are other terms, no, that imply mycetoma. So they are also acquired through traumatic inoculation with several types of saprophytic fungi, and they commonly involve the lower extremities, although they may also occur in other parts or sites of the body, but oftentimes in the lower extremities. All right, so this is how the Madura foot, maduromycosis or mycetoma will look like. Of course, this is already in extremes of cases when they are left untreated, so they become more severe, right, in appearance. So this actually starts with just a puncture, okay, and then that is the portal of entry of the fungi, no? And then affecting the deeper portion of the skin. If you will notice, there are, yes, these are pus or purulent secretions that are coming out. So we usually, if you look at this under the microscope, there are sinus tracts, no, that will be formed, and then these sinus tracts will have communication on the surface. That's why you're able to see the discharges now on the surface. Actually, there are two types of mycetoma. The one that is caused by bacteria, we call it as actinomycotic mycetoma. So these are the bacterial agents associated. We have those belonging to the actinomycetes group, and that includes actinomyces, streptomyces, and then nocardia. And then the eomycotic, these are the fungal causes of mycetoma. And the most common etiologic agent is the Pseudo-Aliceria boydii. Although there are other fungi that is also associated, and that includes the Exophiala gensalmi. All right. The third one is the chromoblastomycosis, also referred to as chromomycosis. Again, this is acquired through traumatic inoculation and then affecting the subcutaneous tissue. This is also a chronic infection, and most of the time the lesions are described as warty, or it is cauliflower-like or tumor-like lesions that again may occur in the lower extremities. Okay, so these are the different lesions that you have. It may occur in the upper, but oftentimes in the lower extremities. So can you see the lesions that are warty or cauliflower-like? And as I have mentioned, this is a chronic infection, so it is acquired through trauma, right? When you have trauma in the lower extremities, for example, that is the site of entry of the fungi, and then affecting the subcutaneous tissues, and that if it is left untreated, then it becomes something like this one. All right. Now, what are the etiologic agents associated with chromomycosis? So these are the three species that are mainly associated with chromomycosis. We have the Cladosporium carioni, the Phyllophora verrucosa, and then the Fonsasea pedrosoy. So what have you noticed? These are what? These are dematiaceous fungi. So when you say dematiaceous, these are fungi that produce melanin-like pigment, and therefore the structures, the fungal structures are dark in color, the colonies are dark in color, and then also the lesions may appear dark in color. Now, we mentioned last time, this one we had given already, that the histologic hallmark of chromomycosis or chromoblastomycosis in the tissues is known as the sclerotic body. So you remember this one? So we describe this as what? Copper-colored septate cells that appear to be dividing. So whenever you see these sclerotic bodies, it is almost always referable to infection uh, caused by organisms, right? Fungi that are associated with chromomycosis or chromoblastomycosis. All right, this one in the tissues. So this is the copper-colored septate cells. So these are the sclerotic bodies. All right. Now we will leave fungi. Let's now go to another group of infectious agents that are associated with skin infections, or that usually will manifest now with skin lesions, and these include the following. We of course will be taking up only the most significant ones, no, the most common that are associated with skin infections. So we have Staph aureus, Staphylococcus aureus, Streptococcus pyogenes, Pseudomonas aeruginosa, the Mycobacterium leprae, and Rickettsiae. All right. Now, before we proceed with the discussion of the individual bacteria, we would like to mention that as far as bacterial agents are concerned, there's a pattern of the discussion. So when you describe the etiologic agent, these are the pattern that is being followed. So most of the time we start with morphology. Okay, when you say morphology, that includes the gram staining reaction, meaning you say whether the organism is gram positive cocci in clusters, gram positive cocci in pairs, or gram positive or gram negative coccobacilli. And this will also include the type of culture media, okay, and then what is the characteristic colonies that are formed, no, in the culture media. So oftentimes this will give us the culture medium of choice for growing the bacteria, and then what is the typical colony that is produced. And then after that, we will start discussing the antigenic structure. So what you understand the term when you say antigenic, that means that these are antigens that are present in the bacteria that can stimulate an immune response, no? Whether antibody production or whether cellular, so humoral or cellular immunity. And also this will include the virulence factor. When you say virulence factor, these are the factors that are associated with its pathogenicity, or the ability of the bacteria to produce infection in the host. So we call them as the virulence factor, or we also refer to it as the determinants of pathogenicity. And then after that, we'll go to the pathogenesis, so the mechanism of disease production. And then this will also include the clinical manifestations that is referable to the disease that is produced. And then afterwards, very significant is the laboratory diagnosis. So what are the tests that you're going to request, no, for you to be able to make a final identification? So of course, it will start with what? What clinical specimen are you going to use? What is the best clinical specimen that you will collect from the patient, and the probability of getting a positive result, no, will be high, no? So that is significant. So what are the laboratory tests? And then next one will be the drug of choice, no, for treatment. So again, I will mention that oftentimes if it is in microbiology, we will just mention the drugs, no, that are used for treatment. Okay, very rarely do we discuss the dosage, or how long you will give the drugs, because we will give that to pharmacology. But what is more important is that you will be able to know what is the drug of choice that is used. So for example, penicillin G, okay, or cephalosporins. Okay, so those are the ones that we will just mention. Sometimes we will mention the dosage if it is significant, all right, or for how long are you going to give the antibiotics. And then of course lastly will be epidemiology and preventive measures. So epidemiology will usually include the distribution of the disease and what is the age incidence, the risk factors, and sometimes it even will include the discussion of immunity, and then of course lastly will be the preventive measures. So preventive measures are significant, right? Because we would like to know how to prevent the disease. So I think what is more important also for you to remember when you want to prevent and control the occurrence of the infection is how the infection or how the organisms are transmitted, right? Or how do we acquire the organism? So that will be a significant information. All right, let's start with staphylococci. Okay, so staphylococci, so I'm sure you had this already in the laboratory. You have seen how it looks like under the microscope, and I think you also have seen how the colonies will look like on blood agar plate. So of course, staphylococci will tell you the morphology, right? So the morphology is what? Cocci in clusters or cocci in groups, or we call it as staphylo cocci. So they're gram positive, of course. And then the colonies on blood agar plate, BAP stands for blood agar plate. They're described as rounded. It has a smooth, raised, glistening, white to gray to deep yellow. So there are species of staphylococcus that will give a deep yellow pigment, no? Although you do not see that often. Now, if they will have hemolysis on blood agar plate, they usually are beta hemolytic. So we will discuss hemolysis later on, okay, when you go into streptococcus. But just we will show also some picture on how beta hemolysis will look like on blood agar plate. So staphylococcus is ubiquitous. They're widely distributed, and even they're part of the normal flora that you have in the body. And in many instances, they often acquire resistance to antibiotics. So we will mention the process of resistance later on. They're also quite resistant to the process of heat and drying. Okay, so they can persist for a long period of times, therefore in fomites or an inanimate object. So this is the gram-positive appearance of the organism. So very typical, right? Now, one of the enzymes produced by staphylococci is coagulase enzyme, and this enzyme is significant because it is a virulence factor for the species, no, Staphylococcus. So that when you say coagulase positive staphylococci, it always refers to Staphylococcus aureus, because among the species that we have for Staphylococcus, it's aureus, it's Staphylococcus aureus that is considered as the most virulent. So they produce coagulase enzyme, and they result to clotting of plasma. So we will discuss the procedure in a while. Whereas the coagulase negative staphylococci are usually of low virulence, and there are two species that are commonly associated with human infection. That is Staphylococcus epidermidis, all right, which is usually associated with prosthetic implant. If you remember the discussion that we have for bacterial biofilms. So these are the bacteria that will aggregate and attach to solid surfaces. So this is one of those organisms that are implicated or associated with bacterial biofilms. And we mentioned that staphylococcus are normal flora, right, of the skin, of the nasal mucosa, and in several other sites. But in the skin, the predominant microbial flora in the skin is Staphylococcus epidermidis, right, on the skin. Now, Staphylococcus saprophyticus is associated with urinary tract infections, like cystitis. What is the meaning when you say cystitis? This is an inflammation of the urinary bladder, and it usually occurs in young women, no, sexually active young women. So this is one of the etiologic agents of urinary tract infection in this age group. So this is the procedure that we have for the coagulase test, and I am sure you also have this in the laboratory, and it's extensively discussed in the lab. But this is the best tests that will differentiate your Staphylococcus from aureus from other species of Staphylococcus. So we know that Staph aureus is positive while the rest of the Staphylococcus species are negative, no, for coagulase test. And there are two types of coagulase enzyme. We have the free and the bound coagulase. And therefore, there are two tests also that is used to detect the presence of coagulase enzyme. One is the slide coagulase. So as the name implies, the test is performed through the use of microscopic slides. And this particular test will detect the bound coagulase. When you say bound coagulase, these are the enzymes that are bound into the membranes, no, of the Staphylococcus organism. And when you perform the test, a positive result for slide coagulase test is clumping. Clumping, just like what you see in blood typing, right? So clumping or agglutination, right? So that's what you see for a positive slide coagulase tests. Okay, so this is how it looks like. So this is positive, clumping, okay, and this is negative, okay. So homogeneous, and you do not see any clumping. Then this is a negative coagulase test, and this one, okay, for a while. So this is negative, all right. You don't see any clumping, but here you see clumping. So this is a positive coagulase test, slide coagulase test, and it's a negative slide coagulase test. All right, the second type of coagulase test is the tube coagulase test. So obviously, we're not using glass slides here, we're using test tubes, okay? So these detect both the free and the bound coagulase. Okay, so when you say free, that means that the coagulase is found around the organism, free, okay? And this one has a different procedure because the positive result is clotting or coagulation, and this usually occurs after incubation, after 4 to 24 hours of incubation. Okay, so this is how they look like. Okay, so the reagent actually that we use for both the slide and the tube is plasma. So plasma, 0.5 cc of plasma is placed in a test tube, right? And then you now inoculate it with the test organism and then incubate this at 37 degrees Celsius for 4 to 24 hours. Then a positive result will be seen as clotting or coagulation. So take note, clumping is a different one, and clotting is it looks different, right? And the same with clotting and coagulation is the same. So this is the tube coagulase. This is the one that is positive. Okay, so this is coagulation or clotting, and this is a negative result for tube coagulase tests. Alright, the principle of the test will be what? Coagulase. We said that the reagent that is used is plasma, right? So whether it is slide or tube coagulase, the reagent that is utilized is plasma. So I am sure that you had that in the laboratory. There is a factor in the plasma. We call it as the coagulase reacting factor, or CRF. No? So that's coagulase reacting factor that is present in the plasma, okay? And when this now will react with the coagulase that is produced by the organism, okay, so plasma inoculated by your test organism. So if the test organism will produce coagulase enzyme, coagulase will combine with coagulase reacting factor, and this will produce a thrombin-like substance. And you know that what is the action of thrombin? It will activate fibrinogen, and then fibrinogen will be converted into fibrin clot. Okay. So here, what happens here is, okay, so you have Staphylococcus. When you utilize coagulase test, a positive result is Staphylococcus aureus. And as we have mentioned, a negative coagulase test is for Staphylococcus epidermidis and Staphylococcus saprophyticus. Okay, so why is this the production of a clot, no, or fibrin clot considered as a virulence factor? Why? Because when the clot is produced, it may coat the organisms, okay? It coats the organism, and the organism now becomes resistant to phagocytosis, okay? So that's one reason why the clot formation is secondary to the reaction between coagulase enzyme and CRF, or coagulase reacting factor, right? So the fibrin clot will coat the organism, your staphylococcal organism, and will render them resistant to phagocytosis. And also, if individuals develop abscesses, right? Abscess because of staphylococcal infection. Again, the presence of coagulase enzyme will react with coagulase reacting factor in the plasma, and then this again will surround the lesion, right? The abscess, and that makes the abscess inaccessible, no, to immune cells and even to antibiotics, no. So that's one also of the reason for the virulence, no, associated with the presence of coagulase enzyme. All right. Now let's go to another enzyme. We have catalase enzyme. So catalase enzyme is also produced by staphylococcal group of organisms, and I am sure you also had this in the laboratory. The procedure here is what? What are we going to use, no, as far as the test is concerned? So this is performed together with the staphylococcal organism coagulase. So we can also perform catalase test at the same time. So the reagent that is used here is hydrogen peroxide. Okay. So hydrogen peroxide, when you now inoculate it with a test organism, and if the test organism produces catalase enzyme, what happens? What happens? So the catalase will hydrolyze your hydrogen peroxide into water and oxygen. That's why a positive result, if you try to look this one, is bubble formation because of the generation of oxygen. Okay, so hydrogen peroxide, when acted upon by catalase enzyme, will hydrolyze into water and oxygen. So that's why you produce this bubble formation. This is a positive catalase test here, and this one is a negative catalase test. So what is the significance of the catalase enzyme? Now, if you're trying to test gram-positive cocci, whether it is Staphylococcus or Streptococcus or Pneumococcus, okay, when you perform catalase tests, okay, this will now differentiate your Staphylococci or the species of Staphylococci from your Streptococci. So this will differentiate your Staphylococci from the other gram-positive cocci, and that includes your Streptococcus. It also includes the Pneumococcus later on, we will mention. Okay, so again, coagulase test differentiates your Staphylococcus aureus from the other staphylococcal species, whereas catalase test will differentiate your Staphylococcus from the other gram-positive cocci. Okay. Now, to continue with Staphylococcus, so the pathogenesis of disease production for Staphylococcus is actually a combination of the effect of extracellular factors, so that will include the enzymes that we had mentioned a while ago. Toxins, there are toxins that are produced by Staphylococcus, so particularly exotoxins, and then the invasive property of the organism. So it's a combination of these three factors, okay, that will be responsible for the pathogenesis of staphylococcal infection. Now, what are the other factors that are present in the cell wall? So teichoic acid, I think you still can remember that teichoic acid is characteristic of gram-positive cell wall. It is not present in the gram-negative cell wall. So teichoic acid is antigenic. That means that it can stimulate the production of antibodies, for example. And then the cell wall virulence. So I think you can also remember that the primary component of your cell wall are peptidoglycan. Okay, so that's the primary component of your gram-positive cell wall. It has a very thick peptidoglycan, and peptidoglycan can stimulate the production of interleukin-1, which is an endogenous pyrogen. Interleukin-1 is produced by many cells, and that includes macrophages. No? So macrophages can release interleukin-1. Interleukin-1, as I have mentioned, is an endogenous pyrogen, and therefore when you say endogenous pyrogen, this can stimulate the thermoregulatory center in the hypothalamus, okay, producing fever. And then, they also can induce the production of opsonic antibodies. So I think you still can remember what opsonization is. So they act as chemoattractant for polymorphonuclears, chemotaxis, no, for polymorphonuclears, and they also act as endotoxin-like, meaning that if you still remember, one of the biologic activities of endotoxin is they produce gram-negative shock or endotoxic shock. So peptidoglycan can also induce the production of shock, okay, but it is not as severe as the one that is produced by endotoxins of gram-negative organisms. So they can also activate the complement system. Another cell wall component is protein A, that's present in your Staphylococcus cell wall. So this one binds to the Fc portion of your immunoglobulin G or antibody G, IgG. So again, this will act as anti-opsonin, anti-phagocytic, and they also have adhesive property. Now, the enzymes produced, aside from the ones that we had mentioned already, the coagulase, the catalase, they also are capable of producing hyaluronidase enzymes. So I think you can understand the function or the action of your hyaluronidase. They will now dissolve the hyaluronic acid, which is the major component of the ground substance, right, in the connective tissue. So that will facilitate the spread of the organism. So staphylokinase will lyse a clot, okay? They lyse a clot, and therefore whatever organisms that are trapped in the clot can now be spread, through the blood circulation perhaps. And then lipase, and then beta-lactamase. So this is another enzyme. Beta-lactamase is significant for resistance to antibiotics, particularly penicillin. So they break the beta-lactam ring of your penicillin, and therefore the organism becomes resistant to penicillin. Now, cytolytic, when you say cytolytic, that means that they destroy cells, right? Cytolytic exotoxin, so there are 4 types, the alpha, beta, gamma, and delta toxins. Hemolysins are also produced. They polymerize, they destroy the membranes of your host cells, or they can destroy the membranes of your red blood cells, right? Causing lysis of your red blood cells if you say hemolysins. The Panton-Valentine leukocidin, as the name implies, it destroys the cell membrane of your white blood cells, white blood cells. And then the super antigens. So we mentioned this last time, right? What is the significance of the super antigens? They will initiate, or they will result to the production of cytokine storm, right? If you still remember. So super antigen stimulate enhanced T cell responses, causing toxic shock. And one of the products of your Staphylococcus aureus that is considered as a super antigen is your toxic shock syndrome toxin, or TSST. Alright, and then exfoliative toxin, so they are responsible. It is also a super antigen, and it causes the scalded skin syndrome that are usually seen in children, especially infants. We will show some pictures later on. And then another super antigen is the enterotoxin. So as the name implies, entero, that means its effect is in the gastrointestinal tract. So there are 15 enterotoxins that are produced by Staphylococcus aureus, designated as capital letter A to E and G to P. These are heat-stable exotoxins. So remember, exotoxins generally are heat-labile, right? So they're easily destroyed by heating. But this one is an exception. So they're heat-stable, and they particularly stimulate the vomiting center of the brain, okay? And at this point in time, I would just like to mention for you to be able to relate, right? So Staphylococcus aureus is considered as the most common cause of bacterial food poisoning. Staph aureus is considered as the most common cause of bacterial food poisoning, and most of the time this is associated with ingestion of food that are rich in carbohydrates, okay? We will mention this again when we go to the discussion of gastrointestinal tract infections. Now, let's look at the different types of infection that is caused by Staphylococcus aureus. So, Staphylococcus actually is considered as a pyogenic bacteria, meaning when they cause infection, they produce pus. So, pus producing. When you say pyogenic, it's pus producing. And let's start with infections involving the hair follicles. Okay, so this is oftentimes precipitated by blockage with sebum or minor trauma. So you remember when you remember histology, the sebaceous gland opens into the canal of the hair follicle. You remember that. So that sebum that is produced by sebaceous gland can block the hair follicle, and that can initiate the inflammation actually. Now, inflammation of the hair follicles, we call it as folliculitis. The most common cause is Staph aureus. and less commonly it is caused by members of the Enterobacteriaceae, or what we refer to as the coliforms. All right, let's look at the inflammation of the hair follicles. So it starts as inflammation of the hair follicles. And as we have mentioned, we call it as folliculitis. Okay, so they may be seen as papules or pustules that are pierced with hair and surrounded by redness. Okay, now when the folliculitis become bigger, okay, then we call it as furuncle. The layman's term is boil. All right, so of course this one has abscess formation already that begins as a red nodule in a hair follicle and ultimately becomes painful, and it is filled up with pus. Then bigger still, this time we call it as carbuncle if the furuncle spread more deeply. So it involves not just the skin, but it can involve the subcutaneous tissues, and sometimes it can even extend into the fascia or into the muscles. So we call it as carbuncle. All right. So this is folliculitis, right? That's inflammation of the hair follicles. All right, that's very easy to understand. Okay. Then the next one is okay, that is furuncle. All right, so furuncle, okay, becomes bigger, right? We call it as boil, right? And then this one is carbuncle, so you notice that it has become bigger, and it has involved already deeper tissues, okay? And what usually happens here is, of course, it's filled up with pus pa rin. So most of the time, if you want to treat this type of infection, you have to incise, okay? We call it as incision and drainage. You have to incise and then remove the discharges, remove the pus, or remove the the dead debris that you have there, because if you do not, then most of the time the antibiotics that you'll be using for the treatment will not be able to access, right, the organisms that are present in the infection site. Okay, so most of the time you do incision and drainage first, and then you give your antibiotics for treatment. All right, so we have mentioned this already. Localized skin infection, we have folliculitis, furuncles, carbuncles, and then there's another infection, we call it as impetigo. It is a common infection, especially in children. So look at this picture. Yeah, it is found on the face, although it can also be found in the hands, it can be found in the lower extremities, no, especially for those children that are running around without slippers, or without, sometimes without pants or without panties. And then you usually see these lesions in the leg, in the lower legs, but this is the typical lesion that you see. So impetigo starts with papule, and then it become pustule, and then it ruptures, and then it will be covered by a crusts. Okay, so that's the one there. So that's what we refer to as impetigo. Now, aside from localized infection, the organism can be brought by the blood circulation into sites like the bones. So inflammation of the bones, we call it as osteomyelitis, or it can be brought into the joints, right? And the inflammation, we call it as arthritis. So these are caused by organisms that are brought by the blood circulation to these sites. And then this one is, it's a severe, or it's a serious infection of the endocardium of the heart. So Staph aureus is one of the etiologic agents causing acute endocarditis, and this usually follows individuals that are intravenous drug abusers. Okay, so aside from this one, so the patient can have septicemia. Okay, so I think you now know the difference between bacteremia and septicemia. All right, so other infections, we have pneumonia, so it can reach the lungs. Okay, and then another infection, I think you have also mentioned it last time, no? The nosocomial infection, or the healthcare associated infection, right? So this is the the hospital-acquired infection, and Staphylococcus is oftentimes associated with wounds or insertion of catheters, urinary catheters, or even intravenous catheters. So toxinosis is a toxic shock syndrome. Okay, remember the toxic shock syndrome toxin that is produced, and then they also can produce scalded skin syndrome. Do you remember we mentioned scalded skin syndrome? Now, this is a picture of an infant, right, with scalded skin syndrome. So there's an exfoliative toxin that is produced by staphylococcal organism that will cause exfoliation of the skin. So if you will notice, when the skin is removed, right, when there is desquamation of the skin, it leaves a raw red area, no? So this must be very painful, no, for the newborn, for the infant. Okay. Now, resistance of the organism to drugs. So we have mentioned already the production of beta-lactamase enzyme, no? Will destroy the beta-lactam rings of penicillin, okay, and even relatives of penicillin like ampicillin, like amoxicillin, or even some of the first generation of cephalosporins. So these are plasmid mediated, or it can be transferred from one bacterium to another through conjugation, bacterial conjugation. So you review the previous lecture on bacterial conjugation and the transfer of genes, for resistance to antibiotics through plasmids. And then the other mechanism for resistance to antibiotics is when there's an altered access to PBPs against nafcillin, methicillin, and oxacillin. Because when the organism is resistant to penicillin, then the next drug that you're going to use are the nafcillin, methicillin, and oxacillin. And now there are antibiotic resistance against this. That's why you often are able to hear methicillin resistant Staphylococcus aureus. Or another mechanism is there's an increased cell wall synthesis against vancomycin. So vancomycin is one of those drugs that are used as one of the drugs that are used if there's no other drug anymore that can be used. So parang it's one of the last resort, as far as treatment of especially overwhelming staphylococcal infection. And then Van-A gene, from Enterococci, so VRS-A. So these are the most important mechanisms for resistance to antibiotics as far as the Staph aureus is concerned. But the most common that we have here is your beta-lactamase production. That is why most of staphylococcal infection are not they are not treated anymore with the use of penicillin, because quite the very high incidence of resistance to penicillin because of beta-lactamase production. Now, let's look at the laboratory diagnosis. Okay, so of course, laboratory diagnosis will be based on the collection of specimen from the sites of infection. You can swab the area, the abscess. You can aspirate the abscess or whatever. You can do blood culture or whatever. So depending on the site of involvement. So this tabulation will at least summarize the laboratory tests that are used to differentiate the three species of Staphylococcus. So you remember coagulase? Okay, coagulase is positive for what? Staphylococcus aureus. It is negative for epidermidis and saprophyticus. Okay. Then what about catalase? Catalase test. Catalase test will be positive for all species of Staphylococcus. Okay. Because catalase test is used to differentiate your Staphylococcus from the other gram-positive cocci. So the color of the colonies, okay, so Staph aureus may produce golden yellow, but not all of the time. So white to gray for saprophyticus and epidermidis. What about fermentation of mannitol? Mannitol is a carbohydrate. It's a sugar, right? So mannitol is fermented by Staph aureus, but it is not fermented by epidermidis and saprophyticus. Novobiocin is an antibiotic, so resistance to antibiotics. So that is true for saprophyticus. Okay, resistance to novobiocin, antimicrobial agent. Okay, so this is the growth of the colonies of Staphylococcus on blood agar plate. So as I have mentioned, some may produce yellowish lipochrome pigment, right? but in many instances they can be this white to gray or opaque colonies of staphylococcus on blood agar plate, and this is hemolysis on blood agar. Okay, so uh, Staph aureus generally, if they produce hemolysis on blood agar plate, it is beta hemolytic. So can you see this clear zone around the colony? No, that is beta hemolysis. That means that the organism uh, cause hemolysis of the red blood cells around the colony. That's why you are able to see a clear zone of hemolysis around the colony. So that is what is meant when you say beta hemolysis. Okay, so Staph aureus, as we have mentioned, it's normally found in the skin, in the nasal cavity. So nasal carriage of Staph aureus is occur in about 20 to 50% of humans. Meaning, if you are a carrier of Staphylococcus aureus, usually you carry it in the nasal mucosa. Okay, that's significant. So the chief sources of infection are shedding from human lesions, or you can have contaminated fomites, okay, or respiratory tract secretions, and also the skin. Okay, so the one that are vulnerable as far as staphylococcal infection is concerned in the hospital setting are the babies in the nursery, right? The patients in the ICU, all right? Or the operating rooms and the delivery rooms. So those are critical areas in the hospital where you may be able to acquire this. So you have to be very careful with the choice of your personnel, right? Especially the nursing staff. Generally, if they're assigned in the nursery and in the ICU, they should have a regular nasal swab, no, to detect the presence of Staphylococcus aureus in the nasal area to diminish the transmission, no, of the organism, and of course the immunocompromised patients, no, at are high risk of acquiring the infection. Now for S. aureus, drugs for treatment, 95% resistance to penicillin G, and that is, as I have mentioned, due to the beta lactamase production. So the higher generation of cephalosporins, right, nafcillin and methicillin, and then vancomycin, these are the drugs that can be used for treatment. All right, so after Staphylococcus, let's now proceed to Streptococcus pyogenes. Okay, Streptococcus pyogenes. So when you say Streptococcus, these are cocci arranged in chain. Okay, so before we discuss the organism itself, let's look at the method of classifying streptococci. There are two ways of classifying streptococci. The first one is Brown's classification. So this is based on the hemolytic activity on blood agar plate. This is the one, no, that we had mentioned a while ago, that Staphylococcus is beta hemolytic. So there are three groups, no, as far as hemolytic activity on blood agar plate. So actually, the name of the person responsible for the discovery of this hemolytic activity on blood agar plate is Rebecca Brown. That's why we call it as Brown's classification. We call it as alpha hemolytic if there's incomplete hemolysis or there's incomplete destruction of your red blood cells. And these are usually seen as brownish or greenish discoloration around the colony. When you say beta, that means that there's a complete hemolysis or destruction of your red blood cells, and it is seen as a clear zone around the colony. When you say gamma, that means it's non-hemolytic. Okay? Again, we will show this again. So this one is Staphylococcus, okay? And this will show beta hemolysis. Can you see the clear zone around the colony? That means that there's complete hemolysis or complete destruction of red blood cells. Okay, this is another one. It's beta hemolysis. This is streptococcal organism. And this one, can you see the greenish discoloration around the colony? Greenish or brownish discoloration signify incomplete hemolysis of red blood cells. And this is classified as alpha hemolytic. Okay, and this is true for, can you see this one? Streptococcus pneumoniae, which we will discuss later on when we go into the respiratory tract infections, because this is the most common cause of lobar pneumonia. Okay. Another method of classifying streptococci is based on the presence or absence of cell wall group specific antigen. presence or absence of cell wall group specific antigen, and we call it as Landsfield classification. So if cell wall group specific antigen is present, we call it as Landsfield. If cell wall group specific antigen is absent, we call it as non-Landsfield group. Okay, so what are the members of the Landsfield? They are designated in capital letters. So when you say group A, we have the prototype species Streptococcus pyogenes. Group B, the prototype species is Streptococcus agalactiae. And group D, okay, either Streptococcus faecalis or it is also referred to as the Enterococcus. So there are other groupings, but I will just mention these three because these are the ones that are most common. Now, the non-Landsfield group, this is where Streptococcus pneumoniae belong, and the viridan streptococci. Okay? Streptococcus pneumoniae and the viridan streptococci. Both of these organisms are alpha hemolytic. Okay, alpha hemolytic on blood agar plate. So this is the typical morphology and gram staining reaction. So it is gram positive cocci in chain. Okay. So whenever we mention group A, beta hemolytic streptococci, there is no other organism that is referred to. That is Streptococcus pyogenes. Okay? Do you understand? Again, whenever it is mentioned that you have a group A, beta hemolytic streptococci, okay, this refers almost always to Streptococcus pyogenes. So you remember group A is based on what? Landsfield classification, and beta hemolysis is based on Brown's classification. Okay. So Streptococcus pyogenes also normally resides in the skin, the mucous membranes, and they can invade apparently intact skin or mucous membranes, no, if especially if the immune system is impaired. Okay, transmission is through direct contact with exudates. Okay, so capsule may be produced, but it is not the usual capsule that you see in bacteria. It is primary component is hyaluronic acid, no? So it is not the usual capsule that you see. And then in the cell wall there is a protein, no? We call it as M proteins, which are described as hair-like structure. And the M proteins are considered as a major virulence factor because the presence of this protein in the cell wall of Streptococcus pyogenes render the organism resistant to phagocytosis. So it is a virulence factor, and based on M proteins, right, there are about 150 serotypes of Streptococcus pyogenes that are identified based on M protein. So they're antigenic, okay? And this now will classify your Streptococcus pyogenes into 150 serotypes. Okay, so what are the products, no, that are produced by Streptococcus pyogenes? So they also produce exotoxins and exoenzymes. So just like Staphylococcus aureus, they produce hyaluronidase enzyme. Okay, so as we had mentioned, they destroy the hyaluronic acid of the ground substance of the connective tissue, and they can facilitate the spread of the infection. Also fibrinolysin or streptokinase, right? They lyse a clot, all right? And then pyrogenic exotoxin. So it is also considered as a super antigen. Pyrogenic exotoxins are associated with streptococcal toxic shock syndrome and also scarlet fever. So that's pyrogenic exotoxin as a super antigen. So the hemolysin. So remember we said that they produce hemolysis, no, on they produce complete hemolysis on blood agar. Okay, so they produce complete destruction of red blood cells, showing a clear zone around the colonies. Actually, there are two types of hemolysins, or also referred to as streptolysin. So streptolysin O and streptolysin S. Now, how are we going to differentiate? Streptolysin O is active in the reduced state, meaning that they are active if you inoculate the agar underneath the agar. Reduced state meaning less oxygen. So they are antigenic and stimulate the production of anti-streptolysin O or ASO. Okay, and ASO titer in excess of 160 to 200 units is considered as significant. Okay, so this will be a significant laboratory procedure to determine the infection previous infection with Streptococcus pyogenes, because if you still remember, Streptococcus pyogenes share a similar antigenic determinant with the heart muscles, producing rheumatic fever and rheumatic heart disease, and they also share a similar antigenic determinant with the glomerulus of the kidney, producing acute post-streptococcal glomerulonephritis. That is why it is very important that a previous streptococcal infection should be documented, and the test that you can use is your ASO titer or anti-streptolysin O titer. On the other hand, the streptolysin S, they generally produce hemolysis on the surface, okay, and they are considered as non-antigenic. Okay. Now, clinically, okay, so again, yes, can you see this? They are also the one of the etiologic agents of impetigo. So you remember that we mentioned impetigo. Therefore, if you are being asked for the etiologic agent of impetigo, it is caused by both Staph aureus and Streptococcus pyogenes. So another one is erysipelas. So these are described as very red advancing erythema on the face or in the extremities, no? And next one is invasive disease. So you can have cellulitis, necrotizing fasciitis, or myositis. So that is why Streptococcus pyogenes is referred to as flesh-eating bacteria. We will show the picture in a while. So they cause necrotizing fasciitis or myositis. No? So fascia and muscles, no, will be destroyed. That's why it is referred to as the flesh-eating bacteria. Streptococcus pyogenes also is the most common cause of bacterial sore throat or acute pharyngitis. Now, I would like to point out, although this will be discussed later when we go to respiratory tract infections, when you have a sore throat in 80% or more, okay, so in 85% or more, sore throat is oftentimes caused by a virus, okay? However, when it is caused by a bacteria, the most common bacteria causing acute pharyngitis or sore throat is Streptococcus pyogenes. All right. So this is erysipelas. Okay, we mentioned this as one of the infections. And this is the necrotizing fasciitis, so flesh-eating bacteria. So it infects not just the skin but the underlying tissues. Okay, so it destroys fascia, it destroys muscle. So that's why this is referred to as flesh-eating bacteria. Okay, so medically it is termed as necrotizing fasciitis. So it is caused by Streptococcus pyogenes. Okay, so this one we have mentioned already, right? So Streptococcus pyogenes is associated with post-streptococcal disease. So they develop 1 to 4 weeks after Streptococcus pyogenes infection. So take note, acute post-streptococcal glomerulonephritis, that's involving the glomerulus of the kidney, usually follow skin infection and sore throat. However, rheumatic fever involving the heart, okay, usually follow sore throat infection only. Okay. So this one, we have mentioned this in immunology last time, right? So we considered your Streptococcus organism sharing a similar antigenic determinant with the heart and with the kidneys as a type of antigen which we call as heterologous antigen or Forceman antigen. Okay, so you try to review our lecture on immunology, the types of antigens. Now, how do we go about laboratory diagnosis? So again, collection of specimen will be based on the actual collection from sites, where you have inflammation, all right? You can use blood also for blood culture. You can use throat, okay, throat swab, okay. So this depends on the type of infection. So you can do gram staining. You can grow them on blood agar plate. So remember the characteristics. So gram staining, they are gram-positive streptococci. On blood agar plate, they are beta hemolytic, all right. They are catalase negative. So remember, what is the importance of catalase test? They will differentiate Staphylococcus, which is positive, and it is negative for Streptococcus pyogenes. Then there is a test which we call as bacitracin sensitivity test. Bacitracin is an antibiotic, okay? So actually, when the bacteria is bacitracin sensitive, it is actually a presumptive test for group A beta hemolytic streptococci. And then, of course, the determination or the detection of ASO or anti-streptolysin O antibodies in the serum of the patient. Okay, you had this in the laboratory, all right? Okay, so this is beta hemolysis on blood agar plate. Okay, so these are the colonies surrounded by a clear zone of hemolysis around. This is the bacitracin sensitivity testing. So what is usually done, this is also blood agar. You inoculate, right, the surface of the blood agar with the test organism. Okay, you want to know whether it is Streptococcus pyogenes or other species of Streptococci. So after you have inoculated this, you now plant or inoculate this is an antibiotic disc, right? So the antibiotic present here is bacitracin. Okay, so then you incubate at 37 degrees Celsius. So after an overnight incubation, when the organisms are sensitive to the bacitracin, no, that is diffusing, no, from this antibiotic disc. So when you incubate, the antibiotics present here will diffuse into the agar, and then they will destroy the organisms that are present around the antibiotic disc. So that means that the organisms are sensitive, right, to bacitracin. So this is a presumptive test for group A beta hemolytic streptococci. Drugs for treatment. So penicillin G is still effective for Streptococcus pyogenes. Now, alternative drugs in case the patient is allergic to penicillin, you can use erythromycin or you can use clindamycin, no, for patients as an alternative drug, no, especially for allergy, patients with allergy to penicillin. Okay, so we have Pseudomonas aeruginosa. So I'm sure you have heard of this organism. This is one of the widely distributed bacteria in the environment. It is found anywhere in the hospital setting. They're found in your body. They're found anywhere actually. And what is the significant information that we have here? They're a significant opportunistic bacteria. They also cause significant nosocomial infection. So there are significant bacteria in patients that are immunocompromised. So when you do gram staining procedure, they are considered as gram-negative Coccobacilli. So I'm sure that you have heard or you have seen how Coccobacilli will look like under the microscope. So gram-negative Coccobacilli. So you usually see outbreaks of Pseudomonas infection in the skin and even in the eyes. No, when you are able to swim in contaminated pools, swimming pools, and hot tubs. So these organisms are non-fermentative, meaning they do not ferment sugars. No, they can cause oxidation, but they cannot ferment. And characteristically, they produce pigments, colored colonies. No, so bluish pigment, we call it as pyocyanin, and then fluorescent pigment called pyoverdina. In the textbook, you even have dark colonies, you have red colonies, but these are the most common ones. So you see this is colonies of Pseudomonas aeruginosa releasing the pigments, and when you are able to see these pigments, it is characteristic. So there's no other organism that will show this type of pigment. So you already have your identification or diagnosis. And even in those individuals with abscess, right? When you have abscesses caused by Pseudomonas aeruginosa, especially in patients with diabetic ulcers, no? The secretions or the discharges usually have this type of color that will be produced by the discharges or the pus. So it is already a clue as far as the type of organism that is present. Okay? So the infection in the skin caused by Pseudomonas aeruginosa, this will be mentioned again later on, no? Because Pseudomonas is quite a notorious organism. It's causing infection in almost all areas in the body. But in the skin, the infection, we call it as ectyma gangrenosum. So it's a hemorrhagic necrosis of the skin, often seen in patients with sepsis. Okay, so hemorrhagic necrosis, we call it as ectyma gangrenosum. So this is how they look like. Okay, Pseudomonas skin infection. So these are the drugs. Pseudomonas actually is one of those organisms that are difficult to treat. They're usually resistant to antimicrobial treatment. So that's a problem. No? So usually you use a combination of drugs for treatment. So piperacillin plus aminoglycoside and a combination of any of these aztreonam, carbapenims, fluoroquinolones, and the higher generation of cephalosporins, right, can be used for treatment. Okay, this is the last organism for this lecture. The rest of the bacteria like Mycobacterium leprae, the one that is causing leprosy, and the rickettsial organism, and the viral agents causing skin infections will be taken up in the part 3 lecture of skin infections. Okay, so I'll see you next meeting. Okay, so you stay safe, everyone.